Hello. Do you hear me, dear Prof? I don't hear you. Just, yeah, click on mic at the left to open it.
Now I'm muted now.
Yeah, great. That's very nice. Okay, just 5 minutes to start. Okay.
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 But you can hear me and everything is okay.
It's very good. Very good. Very good. Yeah.
Very good. Okay. And you see my screen as well.
Yeah.
How much time do I have?
Okay, if it is 30 minutes, very good. And
I can't hear you now. You have the music in the background.
yeah, some folklore of Egyptian folklore and Oriental music.
Yes, yes.
Okay.
So how much time do I have?
Yeah, I think maybe 30 minutes to presentation and 15 for questions. Okay.
Okay.
Okay, it's great.
I probably will skip a few slides because I thought that I planned about 40 minutes, but it's no problem. I can easily make it shorter.
Professor Falck, okay, you have all the time. We need to learn from you.
Okay.
Okay, that's great. Can I play music again then to start? Okay.
Okay.
Okay. I can at the first introduce the tutor who is a very big figure in the world of the neurophysiology community. So at first we are in this episodes, we have Professor Falck, one of the eminent professor of clinical neurophysiology, Uppsala University. The topic today is clinical and electrodiagnostic assessment for brachial plexopathy. So I think we have a lot of information, a lot of knowledge. Please, anyone can invite the colleagues in different perspectives to enjoy this topic. I share this webinar at the group of the Egyptian Neuro Rehabilitation and Electroneuromyography Association. So it will be available after this end of the webinar. Any questions, please put it in the Q&A box, please, at the end of the presentations. So the screen with you, dear Professor Falck, okay?
Thank you. It's a real pleasure to be talking to you. Of course, it would be much nicer to visit Egypt, but unfortunately, that is not currently a possibility that we have. Currently, I am in Finland. Actually, I live in Finland nowadays, and here we are at a distance of more than 3,000 kilometers from Egypt. And Turku University Hospital, where I currently work, is here in this aerial view. The city of Turku is a small city with about 180,000 inhabitants, and this is what it looks like in the winter. Right now we are getting into the autumn, and it's about plus 15 degrees, so it's getting cooler already. What we're going to talk about is brachial plexopathies, and if we look at what we see in our EMG lab annually, and here you see a list of the focal neuropathies that we diagnose, and you can see in the list plexus brachialis lesions is fairly high on the list, so we will see about 100 a year of those, of different kinds of plexopathies. So it's an important focal plexopathy. What I'm going to talk today about is about the anatomy, what kind of causes we have that are giving rise to brachial plexopathies. And in particular, I will talk about Parsonage-Turner syndrome, although it's also affecting other parts of the peripheral nervous system, not just the brachial plexus. Talk a little bit about the EMG in brachial plexopathies, and if time allows, I will have a few cases. So let's start with the anatomy. And we have the brachial plexus here consisting of the spinal nerves C5 to TH1. They join together into trunks and again form cords here. Around the plexus, we have various structures that are quite important for the pathology of the plexopathies we see. We have the anterior scalenus muscle, the middle scalenus muscle, and between them we have the plexus coming through, together with the subclavian artery here. And we have the clavicle above the plexus and the first rib here below the plexus. If we look at it schematically, it looks like this. We have the spinal nerves here. They join together to form the upper trunk, the middle trunk, and the lower trunk. And at the level of the clavicle, they divide into divisions and form cords below the plexus here. And we have a lot of different individual nerve branches that leave the plexus. Altogether, there are 15 nerve branches that leave the plexus. If we think about plexopathies, I myself tend to think of plexopathies as those that are above the clavicle and below the clavicle. And the majority of the plexopathies are above the clavicle, and a small minority, 10%, below the clavicle. And if we look at it from a clinical point of view, the supraclavicular part, they tend to more look like segmental organization, like myotomes and dermatomes, while in the infraclavicular part, they tend to be more looking like peripheral neuropathies. What makes life difficult is that the structure of the brachial plexus varies considerably. It's surprising that all textbooks show the plexus identically, but if you look at it carefully, none of the two plexuses are equal to each other. This is a very interesting book, this Bergman's Comprehensive Encyclopedia of Human Anatomic Variation. I think it's a book you should have in every EMG lab because it will give you an idea of how the nervous system varies. And here you see just 6 samples of the brachial plexus. And the worst case scenario you see here, where all the spinal nerves join into just one single trunk. It doesn't look at all as the plexus we are used to. So it's a little bit tricky to localize things in the plexus because of the anatomical variation. The important structures around the plexus are the lung, it's the lung here, and then we have lymph nodes that are not displayed here. The causes of the brachial plexopathies are variable. There's a very nice study from the Johns Hopkins Hospital in Baltimore, where they looked at plexopathies. There were altogether more than 200 patients. And here you see the distribution of various causes. And inflammatory causes was the most common. We had birth injuries, Erb's palsy, trauma, surgery, radiotherapy, neoplasms. And here a small bar with cervical rib, which probably represents thoracic outlet syndrome. If I look at it myself and simplify this, I have this list right here. We have the Parsonage-Turner syndrome, which is the inflammatory plexopathy, trauma, obstetric injuries, iatrogenic causes, different surgery, anesthesia, radiation therapy. Sometimes we have temporary compression and chronic entrapment. That's often called thoracic outlet syndrome, TOS, but I really don't like this term because it's so diffuse and involves a number of other things as well, vascular problems. So I like to call this rather chronic entrapment, which is a neuropathy. And sometimes we see metastatic lesions as well. But a few words about Parsonage-Turner syndrome, which I think is very important and much more common than most people understand. It was first described in 1948 by Parsonage and Turner, and Parsonage was a resident in neurology and Turner was his senior consultant. And what they looked at was during World War II, soldiers that were wounded, they would have a painful peripheral neuropathy somewhere outside of the area where they were wounded. And it's a very beautiful paper. It appeared in Lancet in 1948. And I think about until 2010, not much more was known about this, but since then a lot of information has come about. I like to call it Parsonage-Turner syndrome, but in the literature, it's often also called neuralgic amyotrophy. Especially in American literature, this term is commonly used. The problem with this neuralgic amyotrophy is that many patients don't have any pain, and purely sensory nerves can be affected as well. So we may have a painless sensory neuropathy that is caused by this, and it doesn't make sense to call that neuralgic amyotrophy. There are other names also in the literature, but these two are the ones that are commonly used. Typically, this starts with severe pain, and the pain starts usually in the night. So about 95% will have severe pain in the beginning, and the pain is constant, not related to position like pain in a cervical disc herniation. Sometimes there is no pain. Sometimes it starts with a palsy, with weakness, and that is followed by pain. And often the patient is so involved with the pain that he's not aware of the weakness and the sensory abnormalities that is related with it. The Parsonage-Turner syndrome can affect any peripheral nerves, but it has a predominance for the brachial plexus and the nerves that leave the brachial plexus. It can affect the spinal nerves, so it can be a radiculopathy. Often it affects the nerves that leaves parts of the plexus, long thoracic nerve, supraclavicular, supraspinate, suprascapular nerve, axillary, and so on. In the arm, anterior interosseous nerve. In the literature, it's often called anterior interosseous syndrome, which is not an entrapment, but it's a inflammatory neuropathy. Cervical plexus may be involved. The phrenic nerve, quite often involved actually. The most common cause for an isolated phrenic nerve neuropathy is Parsonage-Turner syndrome. And the cranial nerves may also be affected, in particular the accessory nerve. And sometimes also leg nerves may be affected. Any nerve can be affected by this disorder. Usually it is bilateral, but it's not unusual to have bilateral problems as well. And they are mononeuropathies and often multifocal. So when you see a patient with Parsonage-Turner syndrome, it's very important to take a careful history. Maybe the patient has several episodes during a few weeks. It may start with one on the right hand in upper plexus, and a few days later, he will have something in the left hand. So the history is very important here. Can affect at any age almost. The youngest patient I have seen is 10 years old. There's a male predominance, and it's quite common. According to a Dutch epidemiological study from Nijmegen, they found that this is 1 per 1,000 people per year. So it's much more common than we really think it is. And the problem with this is also that it will recur in quite a few patients. 1/3 of the patient will have a recurrent problem. And that is something, when I see a patient and I explain the patient, I'm afraid of the question, are they going to ask, is this something that is going to recur again? Because quite a few do. There are a number of predisposing factors, and it's important to find those. It can follow surgery. Maybe you do an arthroscopic intervention in the knee, and 4 hours after the surgery is over, you have a severe pain in the arm. Childbirth, unusual physical activity, vaccinations may trigger them, trauma, infection. And usually it starts within a few weeks after the event, but it can sometimes be quite soon. So maybe it's a few hours after event. Patients with diabetes are more prone to this. And it's interesting to see that here obesity may be a protective factor. In our patients, they tend to be all with normal body mass index, the ones we see here. Our understanding of the etiology has also been quite a lot developed. It's definitely immune mediated. All the predisposing events activate our immune system. There may be also a genetic predisposition. There are some genes that will give rise to a hereditary form of this. There's one in chromosome 17. And there are other mutations that we don't know yet exactly where they are. And in addition to the genetic predisposition and the predisposing factors, there may be mechanical factors because the lesions tend to be around joints, and very often there may be preceding repetitive physical activity before this event starts. Imaging studies have also given us a lot of information about this neuropathy. There's a beautiful paper in Muscle and Nerve from 2015 by the Hungarian group by Susanna Aranui, and they looked at ultrasound in neuralgic amyotrophy or Parsonage-Turner syndrome. In mild cases, there was an edema of the nerves. Here you see edema in the nerves, here as well, like this. In a more severe neuropathy, there was a constriction of the nerve. And if it was a really severe one, there would be an entwinement of the nerve. Here you see it on ultrasound, and so during surgery, you see how the nerve is deformed and ringing around itself. So here you see it schematically. You have the inflammation with edema, and you have constriction, and then you have the ones with torsion and entwinement. And this one is severe with no recovery usually, and here you have incomplete, and here a good recovery. The treatment for this disorder is you manage the pain, of course, with painkillers. Some doctors, if they see the patient acutely, will give a short course of corticoprednisone, start with a fairly high dose and taper it quickly. I think if I would have an episode myself, I would take an episode of steroids, but we have no controlled studies that support this. Physiotherapy and, in severe cases, surgery. And there was a recent paper just in August in Journal of Neurology, Neurosurgery, and Psychiatry about how our treatment paradigm is shifting, and we're recommending surgical therapy for the ones with severe changes in the nerve as well. Outcome, 1/3 will have a fairly good outcome, but many patients will have persisting pain and weakness later on after these episodes. So it's not a totally benign disorder. I will not go into details of all these different nerves that can be affected, but I will talk about the long thoracic nerve because there are some practical points in how you examine this with EMG that I think, at least here in our part of the world, all our EMGers are not familiar with. So here we have the long thoracic nerve, which innervates the serratus anterior muscle here. And here you see a young woman, and she has on the right side, she has a winging of her scapula. You see that it's the lower part of the scapula is a little bit protruding here when she's standing. And when she lifts the arms upwards to an angle of 45 degrees, you see how the scapula is winging here and it's falling outside. And here, when you look at it here, you can see that it's a little bit closer to the midline, this scapula, than this one. She made a very good recovery. So a year later, she had no sequelae for this. So she made excellent recovery. When you examine the serratus anterior muscle, the easiest way to do it is to do it from the front side. You can study it from the back also to go from the midline, but that's very difficult, and it's difficult to find and be sure that you're in the serratus anterior muscle. What I do is I put my thumb and forefinger in the intercostal interspaces here, so I know exactly where I have the rib here. Now I can move very confidently with the needle and not be afraid of penetrating the lung, because I will be writing on above the rib there, and it's easy to enter the muscle. And when you activate it, you ask the patient to straighten the arm and put it up in your axilla, like my colleague is doing here, and ask the patient to try to lift me up from my axilla, and that will activate the muscle. It's very, very easy to do the muscle. The recovery is usually very slow, so you shouldn't be upset if you don't see axonal reinnervation before half a year has passed from the onset. So here you can wait and be still confident that something may happen after more than half a year. The hereditary form, here we have a mutation on the chromosome 17, which codes for septin9. Exactly how that predisposes for this is that we don't know. It has variable penetrance and starts usually early in childhood. And they have painful episodes, and they are just like any garden variety Parsonage-Turner syndrome. We have here locally in Turku, we have one family where we have this, and this young man, when he was, I think he was 4 years old, and his sister was born, he had severe pain and was crying when she was brought home from the hospital, and everybody thought that he was upset just because he had a competition now for the attention of her mother. But when we looked at the family more carefully, eventually the sister got an episode of neuritis, and the mother didn't have one until 20 years later. But the grandfather had a phrenic nerve neuropathy, which was very painful. And here we had one uncle with a plexopathy, lower trunk plexopathy, and unfortunately also their children have this disorder. This is different from hereditary liability to pressure palsies in the sense that the EMG is normal in the unaffected parts of the nervous system. So we don't see any abnormalities that would sort of predispose to this. Trauma, quite a common cause for plexopathies. Humerus luxation, shoulder luxation. The typical problem we get is axillary nerve neuropathy, but very often it's combined with superior trunk problems as well. In traffic accidents with motorcyclists falling over and hitting the shoulder on the ground, they will have also a plexopathy, stabbing and bullet wounds as well. So here you see how if you have trauma, the head is tilting to one side and the shoulder is being depressed, and that will cause tension to the brachial plexus, especially the upper part of the plexus. This kind of plexopathy is not focal, but it's diffuse, so it's a stretching of the nerves. So very often they tend to affect even the spinal nerves and quite long distally. Root avulsions, the spinal nerves C8 and TH1 are attached directly to this. They are not anchored outside the spinal cord, so they are easily avulsed. The upper spinal nerve C5 to C7, they are anchored extraforaminally, so they are not that easily avulsed. Erb's palsy, the obstetric plexopathy, and here usually the reason is that the shoulders are wider than the birth canal, and the shoulder gets stuck here during the fetal descent and is stretched and causing a problem with the plexus like this. If I look at Erb's palsy, when I graduated from medical school and started my residency in clinical neurophysiology, I would see fairly regularly Erb's palsies. And I had one of my friends who was a pediatric surgeon. He did his thesis on Erb's palsy and surgical treatment of Erb's palsy. I think today he would have to wait for quite a number of years to get his material together. So the number has decreased significantly during the last decades. So here we have the shoulder dystocia and we have the traction forces. And interestingly, I thought always that if you are doing cesarean section, you are not so likely to have Erb's palsy, but there are traction moments, traction forces also during cesarean sections, so that you may have an Erb's palsy also following cesarean section. The prognosis is usually good. 2/3 make good recovery within a few months. 30% have moderate recovery and 10% have poor recovery. So if you have a total palsy with no improvement within the first few weeks, that's bad news. Horner syndrome, that indicates that it's a very proximal lesion affecting the TH1 spinal nerve. So very much you have here in this case. What the role of surgery in Erb's palsy has is not really clear. Usually the surgeons want to do the surgery around 3 months, especially if you have total palsy, severe palsy with no improvement. An interesting thing you will see if you do a lot of EMG, like myself, you will have patients who are referred for some upper extremity problem, pain, maybe in the shoulder region, and unexpectedly you find inactive EMG changes that suggest an old upper plexus lesion. You have abnormalities in the deltoid, the biceps, and the supraspinatus muscles, but it's not an active or chronic process, but you see just large motor unit potentials and a reduced interference pattern. Then you have to keep in mind that this may be sequelae after an Erb's palsy that the patient himself is not aware of. So you should try to figure out what happened. Did the patient have some problems in his early neonatal period? And usually the mother will be very informative. So you have to have the patient talk with the mother about the problem. Temporary compression, that may happen during surgery, especially in the 80s when there was a lot of bypass surgery. We would see these kind of plexopathies during general anesthesia. And sometimes we see it also in very lean soldiers that are carrying backpacks. Then we come to how should you say, a topic that is a little bit controversial, and I think there are a lot of different opinions, and that is the chronic compression. I like to call it chronic compression rather than thoracic outlet syndrome. And we have different mechanisms that can cause this. We may have an anomalous cervical rib. We may have a fracture of the clavicle that is deformed. And then we have some poorly documented syndromes. I like to call them neuromythology. These are disorders that don't exist in real life, and I don't think they are real, but they exist in every textbook. And one of these is pectoralis minor syndrome, and the other is Galenos anterior syndrome. We will look at those in more detail. We have the cervical rib. It's not that uncommon. 0.3% of people have a C7 cervical rib, and most of them are women. And this, of course, impinges between the clavicle and the first rib, so it gives less room for the brachial plexus. Then we have costoclavicular compression. We have a clavicular fracture that has healed with severe deformity that will impinge on the brachial plexus. These two disorders are distinct, and I really believe that they do exist, and I do see them in my practice regularly, not very often. Then we have this Calenus syndrome. And here the idea is that the plexus is compressed between the scalenus anterior and the middle scalene muscles here. I think the syndrome is very poorly documented, and I think it's a part of neuromythology. The same applies for the pectoralis minor syndrome, where the pectoralis minor muscle will impinge upon the plexus when you lift up the arm. Here you see how it will be impinging here. Well, the symptoms, you have shoulder pain, arm pain, paresthesias, very variable kind of symptoms. There are some tests that are commonly used. David Rose, he's a hand surgeon in the United States, and he devised a test where you abduct your arms, lift your arms like this, and rotate externally, and you flex your fingers for 3 minutes. I cannot do this for 3 minutes. My fingers get tired, and it's abnormal in my own, more than half of normal people, and especially patients with carpal tunnel syndrome will have an abnormality. Another useless test is Adson's maneuver. Here it's based on feeling the pulse, radial pulse in the arms, and you ask the patient to inhale and rotate the head. And if the pulse disappears, that suggests that there is some possibility for compression of the brachial plexus as well. Very poor specificity also for this. And if you want to look at the discussion on thoracic outlet syndrome, I think there's an interesting pair of papers in Muscle and Nerve about 20 years ago, where David Rose, who is a proponent of thoracic outlet syndrome, and Asa Wilburn, who is a deceased EMGer from the Cleveland, they discuss this disorder. I think it's very good to read that. I do think that chronic compression of brachial plexus, it exists, but it's rare. It may be associated with cervical rib or clavicular fracture, but the thoracic outlet syndrome is overdiagnosed, way overdiagnosed. Then we can have iatrogenic plexopathies. The most common form I see is the ones that are related with plexus anesthesia. Sometimes, very rarely, you see it with angiograms that are done transaxillarily and in perioperative surgery. And I see more complications of surgery for thoracic outlet syndrome than I do see real neuropathies in this region. And radiation therapy is a fairly common problem as well. If you do supraclavicular plexus anesthesia, you will have problems in neuropathies will occur in about 0.5% of the neuropathies. And the anesthesiologists are becoming more courageous because they are using ultrasound, so it's easier to locate the plexus and easier to do the anesthesia as well. But no matter which way you localize the plexus, you still get the same incidence of 0.5% on neuropathies. Partly, you may have direct mechanical trauma by the needle. You have the toxic effect of the anesthetic and also the preservatives that are a part of the the drugs you are using. Very rarely you will see intraneural injection of the drugs. Arteriography, direct trauma by the catheter or hematomas. Perioperatively, if you have a long-lasting surgery where your arm is abducted 90 degrees, you may get plexopathy. If you do sternotomy, in the 70s and 80s, there were a lot of patients that had coronary bypass surgery, and there you open up the rib cage, and when you open it up, you will the plexus will be pressed here between the clavicle and the first rib. Cancer, here you have lung cancer, Pancoast tumor. Not so often you see this. Metastasis of the lymph node, sometimes yes, and also if you have radiation therapy for cancer. If you think about the plexopathy that is due to radiotherapy, see that here you have the sensory symptoms in these bars here. As time passes, it increases in frequency. Also the motor involvement, the dark bars here, increases in frequency. So you have to wait some time. Mostly the onset will be a few years after the radiation therapy, but it takes a long time. And probably it's because of the scarring of the tissue, and also the nervous tissue will be scarred. So you will have these. And of course, it's dose related as well. Benign tumors will occur in the plexus. When it comes to the diagnosis here, we have the usual things we do. We take a careful history, look at the clinical findings. Of course, being an EMGer, we do EMG and ENG and imaging studies as well. So we use all of these tools when we do this. Some things you need to think about is, first of all, the brachial plexopathies are rarely focal. The traction injuries extend diffusely along the nerves. Parsonage-Turner syndrome may be multifocal. Gunshot wounds are always diffuse. And if you have Parsonage-Turner syndrome, it affects individual nerves, and you maybe you have multiple nerves that are involved. And the plexus anatomy varies from one patient to the other. When you take history, you want to have an exact idea. When did it start? Was it acute? How did it evolve? Were there several painful episodes, not just one? Sensory symptoms, I myself put a lot of emphasis on the paresthesias the patient has, the skin areas where he feels sensory abnormalities, pain, weakness. Are there any predisposing factors? When I do EMG, I will automatically always ask, do you have diabetes or rheumatoid arthritis? If you have a plexopathy or suspect a plexopathy, any clavicular fractures, any trauma in the region. Test carefully muscle strength. Always look at the winging of the scapula. Tendon reflexes. Look for a Horner sign. If there's a Horner sign, meiosis and ptosis of the eye with loss of sweating over the face, then you have Horner syndrome, and you know it's a lower plexus problem. Well, the goal of EMG is, first of all, to find whether there is a peripheral neuropathy, where is it, how severe is it, what kind of pathophysiology do we have, is it axonal, is there a conduction block, demyelination, what is the time course, is this an acute problem or is this chronic inactive? So we need to demonstrate neurogenic EMG abnormalities. We do urography always, and sometimes it's difficult to differentiate a plexopathy from a radiculopathy. It's not always simple. MRI will often be very helpful in this respect. EMG is not going to give the etiology. that's true for any disorder we diagnose with EMG. We will localize the problem and see how severe it is, but we need the history and the clinical findings, sometimes the imaging findings as well, to be aware of the etiology. Some important aspects from the anatomy when we do EMG is, first of all, the dorsal scapular nerve that innervates the rhomboid. It leaves very proximally from the fifth spinal nerve. That's the only muscle in the body that is has just a single myotome that is innervating it. So if the rhomboid is involved, you will know that it's a very proximal neuropathy. The suprascapular nerve, it leaves the trunk from the upper trunk here. The long thoracic nerve, the branches to that one will also leave very proximally. So we know that if it's involved, it could be very proximal to the spinal nerves. And finally, the medial antebrachial cutaneous nerve leaves the medial cord here. We do different muscles, not going to go into details. I will make this presentation available for you so you can carefully look in detail what muscles I myself like to look at, but I look at the different parts, and I also want to get an idea of the paravertebral muscles. So if there's a spinal nerve involved. We do sensory neurography, median, ulnar nerve, radial nerve, lateral cutaneous of the forearm, medial cutaneous, motor, median, and ulnar, and always F waves as a part of that. When you do the ulnar nerve, I think it's a good idea to stimulate not only down here, just above the elbow, but also up here in the plexus. And when you stimulate up here, you have to use a high stimulus intensity. I mean, 100 milliamperes is not uncommon, and maybe sometimes 0.5 milliseconds duration. And if you stimulate with this stimulus intensity at the wrist, it's extremely painful. But up here, it's not that bad. You should try it yourself if you haven't done it. And here you see what it looks like in a healthy subject when you stimulate the ulnar nerve in different positions. You see here, above elbow, still 17 milliamperes, up here, 99 milliamperes to get a decent response. And we always look at the F responses. The sensory neurography is very important because it helps us to localize also the problem. If you think about the way the sensory nervous system is organized, we have this sensory dorsal root ganglion where the nerve cell soma is located. It's outside here in the intravertebral foramen here. So if you have a disc herniation, it will compress the nerve proximal to the soma. So you will have loss of sensation, but the sensory nerve will still be preserved here. So you don't get an axonal degeneration or severe degeneration, but in spite of the sensory loss, you will have a fairly good amplitude of the sensory response if it's a very proximal lesion. Or if you have an avulsion of the root, still you lose sensation, but you still have a preserved sensory response. But if you have a plexopathy where the problem is down here, you lose sensation and you also lose the sensory response. So here you see what it looks like. Here, you see that this is the medial cutaneous of the forearm in a plexopathy. Very nice response on the healthy side and no response on the affected side. When you look at the different sensory nerves, you have the C6 here, lateral cutaneous of the forearm, radial nerve, C6, C7, median nerve to the index finger, mostly C6, C7, ulnar nerve to the little finger, that's C8, medial cutaneous of the forearm, TH1, lower trunk. So this The sensory responses help you to localize where the problem is. If you have a root avulsion, you lose sensation, but you still have preserved sensory nerve action potential. You have severe denervation of the muscles, and the paraspinal muscles are denervated as well. And here you don't expect any recovery at all. Somatosensory evoked potentials are not helpful in the diagnosis of plexopathies for various reasons. If I have a patient with Erb's palsy, well, the EMG you do is not going to be as thorough as you do in an adult, so you will do a smaller number of muscles. Ideally, I would like to look at these muscles, but it's not always possible. Biceps, deltoides, rhomboides are very important. Biceps, especially because of the functionality of the arm, the biceps is very important. We do neurography on the children as well, ulnar motor, median and ulnar sensory, and radial sensory. If we have a patient with Erb's palsy, we like to see the patient 2 to 3 weeks after the child is born, and for follow-up at 3 months when the surgeons are keen to do the surgery if they're going to do surgery on the child. MRI and ultrasound, especially ultrasound, is becoming much more important than it has been before. Helps us in the differential diagnosis, root avulsions and radiculopathies. We see tumors, pancreas tumors, and MRI may show abnormalities on Parsonage-Turner syndrome, and ultrasound definitely shows abnormalities in Parsonage-Turner syndrome. Here we see a patient with a metastatic plexopathy, and you see the abnormalities here. Differential diagnosis, you have cervical radiculopathy due to disc herniation. In our part of the world, we have Lyme disease, borreliosis, a tick-borne disorder. Often this is combined with facial palsy, so it's easy to differentiate it. You have polyradiculopathies and facial palsy. Multiple mononeuropathies in vasculitis, some immune-mediated disorders, Lewis Sumner, multifocal motor neuropathy with conduction blocks, and we have some infectious neuropathies as well. Now, a few patients that we look at. Here we have a woman, 67 years, and she's been treated for right-sided breast cancer, radiation therapy. Follow-up showed no recurrent tumor, and 4 weeks prior to EMG, there was a severe pain in the arm with paralysis of the elbow flexion and arm abduction. And clinically, shoulder and elbow muscles were weak. Distal hand muscles had good strength and loss of sensation over the upper arm. A little bit in the fingers as well. And here you see the sensory median nerve responses. No response from the thumb or the index finger, but a small response from the middle finger and the ring finger. EMG showed changes in the infraspinate, supraspinal, deltoids, biceps, triceps, flexor carpi radialis, and extensor indicis. So clearly widespread problems here. But in the rhomboids, there were no abnormalities. Trapezius was normal, and the hand muscles were normal as well. So we see that there's a severe acute upper and middle trunk lesion, and the acute onset with severe pain suggests Parsonage-Turner syndrome rather than any complication related with her breast cancer. The pain subsided a few weeks, and follow-up at the oncology department didn't show any metastatic lesions, and muscle strength recovered slowly at 3-4 months after the onset. She was left with some sequelae, but we think this was a Parsonage-Turner syndrome. The next patient is also an older lady. She had also breast cancer 18 years before, And 5 years ago, surgery for lymph node metastasis, same side. Twice radiation therapy in the left axilla. And now for about half a year, progressive weakness and pain in the left arm. She has atrophy of the proximal shoulder muscles, especially the deltoid. The upper arm abduction is weak. Elbow extension is weak, the triceps. Finger extension very weak, extensor digitorum. Strong in finger flexion, strong in elbow flexion. Biceps and brachioradialis reflex is normal, no triceps reflex. No sensory abnormalities that she was aware of. And here we have the EMG again. Deltoid showing severe chronic neurogenic changes, triceps, chronic neurogenic changes, and extensor indicis, chronic changes. So we see abnormalities only in the axillary nerve and in the radial nerve in innervated muscles. And here we see the sensory nerve action potential, lateral cutaneous of the forearm normal, medial cutaneous normal, median nerve, all responses beautiful, ulnar nerve beautiful. Very often we see carpal tunnel syndrome in ladies of this age, but she doesn't have even that. Radial sensory is not there, and we're not surprised. So here we have a very focal problem in the posterior core. The posterior core divides into the radial and the axillary nerve. It's quite rare to see such a focal abnormality in the brachial plexus. And here, well, Parsonage-Turner syndrome doesn't behave like this. This was a chronic problem that was evolving over a long period of time and progressed steadily. Radiation therapy, well, if it would be a radiation complication, it would be much more diffuse and not only a very focal. So we suspect that it's a metastatic problem here. And MRI showed a tumor below the clavicle, which was found to be a metastatic problem. And still one more patient. This was a 69-year-old female ophthalmologist, and she had infraspinate and supraspinate tendons were ruptured, and she had surgery a few months later, ultrasound-guided interscalene regional anesthesia, and immediately after surgery, there was severe shoulder pain. Pain subsided 3 weeks later, and after surgery, she felt short of breath and unable to sing. Neurologically, there was nothing really to be found on neurological examination. And interestingly, a neurological colleague of mine was the first one to examine the patient. And he listened to the lung sound and found no breathing sounds on the right side. So he referred the patient for EMG, and then we do neurography. We stimulate up here, record the response here, like this. Here you see the unaffected side, a beautiful response. And on the unaffected side, we see, we're not really sure whether this is a response or some artifact, but it's a very small response. EMG, we go into the lower interspaces here, like this. And there was severe fibrillations and no voluntary activation at all. Chest X-ray, no sign, or you see that the diaphragm is elevated here on the affected side. And the outcome was poor. She made no recovery at all. So here we see an anesthesia-related problem with the phrenic nerve. So this is my story of the plexopathies and few illustrative cases. So thank you very much for your attention. Here in Finland, one of the most popular books that everybody reads is called it's by an author called Mika Valtari. It's called Sinuhe the Egyptian. And it's a story of a Egyptian doctor during Pharaoh Akhenaton 1300 before our onset of time calculation. It's a beautiful story, and everybody reads it, particularly doctors. So for those of you who are keen to have a handout of the presentation, it's so large, so it's difficult to send it by email, but I will share it over a Dropbox. So if you write your email, an email to me, I will send you a link so you can download it. A few years ago, we ran a course together with Eric Stolberg. We've been running courses over a long period of time, but we videoed one of our courses, which has 20 hours of lectures on EMG. And that is available free of charge for anybody to view. So especially if you have residents who are interested in learning different things about the various EMG techniques and various neuromuscular disorders, it's for you to download. So thank you.
Okay, it's really today it's a privilege for us to join Professor Bjorn Falck, which really I attended all the videos and the courses in Uppsala with Professor Eric Stolberg, which is amazing. I support to teach and learn from these videos and these episodes. So I think we have a lot of questions to be lucky to join you, dear Prof. First, I'm really surprised to connecting today both electrodiagnosis and clinical issues, which is very, very good and amazing. Then, which what I said today is the combination between the electroneuromammography and the ultrasonography, which is today, I think it is mandatory to every lab to get both the electrodiagnosis and adjusting to it the ultrasonography to solve what about the cause. It's really surprised me. So in complete brachial plexus, obstetrical complete plexus lesion in infant about 6 months, sometimes the hand surgeon get a referral for electrodiagnosis, but he want to know what about the nerve root avulsion. He requests the child or the infant 6 months for electrodiagnosis lab with getting a question mark avulsion roots or not. So the EMG in this age can get a clue for this? Or what about your thoughts, dear Professor?
Well, the babies are always tricky because it's so difficult to record reliably the sensory nerve action potentials.
Right.
That is a main difficulty we have in diagnosing the avulsions. But I think you can presume that you have a root avulsion if you have total denervation of the deltoid, the rhomboid muscles, and you find fibrillation potentials in the paraspinal muscles as well. What we are often asked to do is to go into the operating theater as well. And here it's very helpful because then you can see the nervous structures and you can stimulate the different structures. And then you can stimulate the upper trunk and see whether you get a somatosensory evoked potential. And then you know that, okay, now we don't have an avulsion in this case. But of course, then you have to do it intrasurgically. So it's then you already have decided to operate.
Yeah,
I think it's very tricky, and I really don't. I'm not really convinced how much the surgery is helping the patients in the outcome of these neuropathies. It's not really that clear.
Okay. In our clinical practice, can we say clump paralysis only?
Klumpke's paralysis, by that you mean that you have a paralysis of the lower plexus. I rarely see that kind of obstetric plexopathy, really. It's very, very unusual to see that. It's usually the upper plexus is usually what we see here.
Yeah. I noticed something from the demo of your case study. In the first two case study, you just do the sensory and needle imaging. What about the motor electroneurography?
Well, it's very helpful because it will, especially if you have a lower plexus problem, then the amplitude of the motor response will reflect the involvement of the motor fibers. But especially if you have, theoretically at least, it would be very interesting to see if you look at the ulnar nerve, to compare the response above the clavicle and below the clavicle. So if we would have more real thoracic outlet syndromes that were due to costoclavicular compression, and theoretically you should see a conduction block there. But the problem is that it's so difficult to stimulate reliably the plexus above the clavicle. So I put more emphasis, if the finding is normal, then I think that it's very unlikely that the patient has a costoclavicular compression. But if you have an obese patient, it's very difficult to stimulate the upper part of the plexus because you can't get the current there. The distance to the plexus is too far away and it becomes very painful.
Okay. I think I need to ask you about the true or the neurogenic thoracic outlet syndrome. In the early stage, we can rely upon only the abnormality of the medial antebrachial cutaneous.
Now I didn't quite understand your question. You are talking about the medial cutaneous of the forearm.
Yeah. In acute stage, the first acute stage, few days of the anyone suggesting any pain radiating in the inner aspect of the arm, it may refer for it to diagnose just the only finds in the abnormality of the medial cutaneous for the forearm.
But okay, yeah, I understand. Right, right. Well, of course, the problem we have is that if we are going to diagnose a neuropathy in the very early stage, days from the onset, we would have to be able to measure across the lesion. If we are measuring downstream from the lesion, the problem is that the denervation activity in the muscles, the fibrillation potentials will develop only maybe 10 to 14 days later. And if you cut a nerve, I mean, 3 days after the severance of the nerve, still below the lesion, you will be able to record a normal action potential. So in the acute state, sometimes it will take up to more than a week before the sensory axons degenerate and you don't get a response. So you have to be very careful about the sensory nerve action potential. It will not be gone immediately. So it will take some time before it disappears. Okay. The motor response will disappear much quicker than the sensory. Because the neuromuscular transmission will fail in the degenerating motor axons. But if you look at the sensory axons, when we do neurography, we're only looking at the section of the nerve. We don't look at the receptors and we don't look in the proximal part. Yes.
Yeah, I think it's very, very great and very amazing talk and presentations and explanation for a lot of questions in our brains. So at the end of this presentation, I would like to thank you for your times and this a lot of knowledge and informations and learning also. So I hope in next time to share us again in a new topic. Thank you, dear Professor Falck. Thanks a lot. Okay.
Thank you very much, and best regards to all our Egyptian colleagues that are out there.
Yeah. Okay. Bye. Okay. Hope that's okay. Bye bye. Thank you. Okay, all the attendee, I think we have soon, I think the next week with Professor Eric Stolberg in macro EMG. Please follow us, and also as Professor Falck see, we can teach him in email to get the presentation. Thank you again for this amazing talk, and goodbye. Okay, see you. Bye-bye.